All right, so I'm hoping that before class today, you had a chance to go into Canvas to download what I'm going to work with you on. Um, I was hoping to maybe have a little bit more of a chance to do questions with you, but as I was reviewing SquareCap, there were a lot of different topics that we wanted to review today. So basically what we're going to do today is we're going to do a crash course in about 3 of our organ systems to hit some of the stuff that when I was working with you all through the semester, I got a lot of quiz questions or just questions in general about. So one of the most common things that showed up when I asked you all what you wanted to talk about was the endocrine system. And so this picture is a little bit scary, but this picture summarizes almost all of the endocrine system in one shot. Now, I'm going to be honest with you all, maybe a little too honest. When I was teaching this class this semester with you all, you were my first class where I taught A&P together all the way through. I've taught anatomy alone, I've taught physiology alone. So this semester was an in-depth dive for me. And here's what I'll say for you. As I was going back to prepare for today's review session, I realized that I felt like I had learned so much this semester. So I hope that you all feel that way as well as we start to review things. Hopefully some of these things that you think back on that were really hard and scary at the beginning are a little less hard and scary. I know for me, as I was thinking about the different axes, so when we started the semester and we jumped right into the endocrine system, that was a beast. And we talked about the HPA axis and the HPG axis. We did all of that at the top. But as I was going through and looking at this, I remembered we pretty much talked about all of these different parts throughout the semester. So I want to start here with the endocrine system by reminding us that each of these different systems we've worked through this semester. So here's the axis that we did most recently, the HPG axis. And so I want to remind you that when we use this terminology HPG, what we're referring to is the hypothalamus, the pituitary gland, and then the last letter tells us what system we're in. So for HPG, this is the gonadal axis. Let me try to write that on here for us. HPG, the last word in its name is gonadal. So the HPG axis is one of the ways that the hypothalamus sends messages to the anterior pituitary gland. When it stimulates those cells that are part of the HPG axis, they're going to spit out 2 of the hormones that we just talked a whole bunch about in the reproductive system. So that's FSH, follicle stimulating hormone, and that's LH, luteinizing hormone. Both of these 2 hormones that are released by the anterior pituitary gland are going to go down and in the males affect the testes, and in the females affect the ovaries. So the 2 hormones that go down to these structures are reproductive organs, follicle stimulating hormone and luteinizing hormone. But remember, especially from our discussion of the ovarian cycle, that the ovaries make a whole lot of other hormones for the body. So estrogen and progesterone are ones that regulate the uterine cycle very, very tightly, but they're also just involved. This is the primary female sex hormone. So involved in a lot of things. When we talk about the effects on the testes, if you remember in the testes, we had those cells that lived outside of the testes themselves that spit out testosterone. Testosterone causes the testes to start making sperm once someone goes through puberty, but this is also the hormone that circulates throughout the body and leads to those secondary sex characteristics. So what the pituitary gland spits out, FSH and LH, those go down and talk to these 2 endocrine organs or reproductive organs and cause them to spit out the hormones that we're now very familiar with. I'll mention for you one that we didn't really talk about in class, but we see it on here and it's relatively important. That's my bad that we didn't talk about it. See this one right here called inhibin, and we can see it over here as well, inhibin. Its name tells me exactly what it does. Inhibin inhibits the activities of the testes and the ovaries. So once we have a fertilized egg implanted in the uterus, we're going to use inhibin to stop the process of making new potentially fertilizable eggs. Or in males, if we have an abundance of sperm, we'll use inhibin to slow things down. So inhibin inhibits the work of these two organs. These two organs controlled by follicle stimulating hormone and luteinizing hormone, both of which are coming from the anterior pituitary gland. A quick reminder for us that the anterior pituitary gland does make its own hormones. So to control this part of the pituitary gland, we use these things that we talked about that were releasing hormones or inhibiting hormones. So as we think about the posterior half, the back part, these hormones that are spit out don't actually come from the pituitary gland itself. But in this case, in the HPG axis, we're talking about something that does come directly from the anterior pituitary gland. Another hormone that's not technically part of the HPG axis, but also comes from the anterior pituitary gland and is involved in reproduction is prolactin. So remember, we talked about prolactin with pregnancy and development. This is something that helps with preparing for the process of milk synthesis and continuing milk synthesis. So interacting during the process of pregnancy and shortly thereafter. And while we're kind of on this vein, I'll mention that over here, one of my posterior pituitary gland hormones is oxytocin. Oxytocin is the hormone that helps us with the letdown reflex, so the ejection of milk from the mammary glands. Oxytocin is also the hormone that leads to the process of contractions. So it causes the uterus to contract to push the fetus out of the uterus. So very involved in the process of birth, very involved in the process of nursing. All of those, three of those coming from anterior side, and then oxytocin coming from the posterior side. So that's my HPG axis, the gonadal one. Let's move over next door to what's called the HPS axis. When we talk about the HPS axis, we are talking about the axis in easy words that's going to regulate growth. So the HPS axis, the somatotropic axis, this is starts with the anterior pituitary gland releasing growth hormone. Growth hormone goes down. It can influence multiple cells in the body and multiple organs, but the primary one that it really activates is the liver. As the liver is activated, it makes some other things. We have them called somatomedins. You don't have to know this thing, but the one that we talked about, let me put it in the chat for us. Insulin-like growth factor. Insulin-like growth factor. When the liver gets the message of growth hormone, it spits out insulin-like growth factor. That's what actually talks to things like the bones or the muscles, other tissues in your body. When we think about this HPS axis, ultimately what its job is to regulate how metabolism is working so that we metabolize in a way that helps us to make our tissues stronger or help them to function better. So the HPS axis is going to involve growth hormone coming from the anterior pituitary gland. Again, because we're on the anterior side, the cells there actually made this hormone. Next door neighbor, we have the HPT axis. The HPT axis is all about the thyroid gland. So when we're considering the HPT axis, what the anterior pituitary gland spits out is thyroid stimulating hormone. Thyroid stimulating hormone, like its name suggests, talks to the thyroid gland. The thyroid gland spits out hormones, and thyroid hormones, in case we've forgotten, are regulators of metabolism. So remember back from our nutrition chapter, we said you had your basal metabolic rate, the baseline rate of nutrients, how you do metabolism. That comes from primarily from your level of thyroid hormones. So the HPT axis, using thyroid stimulating hormone, activates the thyroid gland, regulates metabolism using thyroid hormones. The last axis that we talked about was the HPA axis, HPA for adrenal glands. So this axis, the HPA axis, we said was the stress response in your body. So the HPA axis uses something called adrenocorticotropin hormone, ACTH. The anterior pituitary gland makes this hormone. This hormone goes down and talks to the adrenal glands. The adrenal glands spit out a variety of hormones, steroid hormones, that circulate through your body at varying levels depending on your stress level. So way back at the beginning, when we first started talking about HPA and HPT, all of these things, to me at least, I presume I'm not alone here, but to me at least, this was kind of intimidating. Like, what does all of this mean? All it means is the hypothalamus is spitting out some hormones that cause the front side of the pituitary gland to spit out its own hormones that regulate things. We only see these axes, the hypothalamo-pituitary axes, with the front half of the pituitary gland. Because if you live in the back half of the pituitary gland, you don't make your own hormones. So there's not an axis that we can do here, because the hypothalamus itself is what's actually making the hormones that are being released. So we already talked a little bit about oxytocin, at least on the female side. So doing things like uterine contractions or the process of milk letdown. In males, oxytocin also contributes to smooth muscle contraction. It's a smooth muscle originator. So this is something that's going to be involved in the workings of the male reproductive tract. Oxytocin from the back half of the pituitary gland. The other one that comes from the back half is ADH, antidiuretic hormone. And we've talked about this one a whole lot lately. With ADH, its goal is to help us to reabsorb water. It acts specifically on that end part of the nephron to help us do that. So ADH, the last thing that comes from the posterior pituitary gland, going down to the kidneys, causing the kidneys to reabsorb water. So antidiuretic means we don't want to lose as much water. Notice that antidiuretic hormone, if we trace it back to the hypothalamus, is coming from what we call osmoreceptors. So osmoreceptors detect the level of water in the body. If the water gets too low, these guys that go all the way down into the posterior pituitary gland spit out antidiuretic hormone. And as they spit out that hormone, it changes the activity of the kidneys. So we've chatted through our axes. Remember, all of those rely on hormones from the front half of the pituitary gland. We've mentioned these two hormones from the posterior pituitary gland. Like I put in a box for you, make sure we remember that the back half does not make its own hormones. In a nutshell, this is almost all of the endocrine chapter on one page. I want to pause for a moment and give you a chance to put in the chat for me, what questions do we have about anything on this particular slide? Are there any questions that jump out to us at this point? Or if not, feel free to send me a thumbs up emoji. So we make sure we're all still tracking with Dr. Ahles, that I'm not talking to the void. Okay, I got at least one thumbs up, awesome. Okay. Yeah, so there's some questions in the chat. Do we need to know the difference between T3 and T4? Let me investigate really fast. What I am doing to investigate this is I am pulling up our list of learning objectives. So let me check. So it doesn't specify for sure if we need to know the difference, but it can't hurt to know. So when we're talking about thyroid hormones, when we're spitting things out from the thyroid gland, let me make sure I don't get this mixed up, because I think I mixed it up in class with you all. all of my searching on Google is failing me here. Let's see. Okay, let me confirm real fast before I lie to you. Okay, so the thyroid gland itself first spits out T3. T3 gets its name because the hormone has 3 iodines attached to it, T3. We use T3 in combination with dietary iodine to make T4. We add an extra iodine to it. So I don't know if you're going to have a question about that, but what we actually spit out from the thyroid gland is T3. We activate it into T4 with that extra iodine from the diet. So if you remember back from our discussion of this axis, we talked about hypothyroidism, that being an issue where the thyroid gland gets really big because it makes a lot of thyroid hormone but can't activate it. That thyroid hormone isn't functional in the body. So that can be an issue caused by low iodine levels. So T3 and T4, technically T3 comes from the thyroid gland, T4 does that activity for us. Let me check out my chat. Yeah, 2 questions about that. Yeah, and I like what Crystal said in the chat as well, how now that we're reviewing the hormones, we actually understand them, right? I totally agree with that sentiment, Crystal, that when I was going back and looking at this, looking at some of those pictures from chapter 16, I was like, oh, this is not nearly as scary as it was, 15 weeks ago. All right, any last thoughts about this one? I'll give us just a moment more because there was one other set of endocrine things that I wanted to mention for us. So the vast majority of the hormones that we talked about in chapter 16 had to do with one of those axes. So had to do with what was going on with the gonads or the thalamus or excuse me, the thyroid gland. But we also talked about how there's a couple other organs in the body that have endocrine functions, but aren't strictly part of those axes. So one of those was the adrenal glands. A quick reminder for us that the adrenal glands have 4 different regions in them. So the outer part of the adrenal glands is called the cortex. The outer cortex makes 3 different kinds of hormones. So it's got 3 different regions to it that makes 3 different kinds of hormones. So the outermost region is called zona glomerulosa. Now, check this out. Dr. Ahles literally just made this connection. Zona glomerulosa, as in glomerulus. Y'all, I think I should put in like the mind blown emoji here. So check this out. Aldosterone is talking to our kidneys. It's having an effect on the process of sodium reabsorption. So aldosterone coming from the outermost part of the adrenal gland called zona glomerulosa, affecting that. The next layer in the outermost part here is called zona reticularis. And when we talk about zona reticularis, this is actually the specific part of the adrenal glands that are involved in the HPA axis. Remember the HPA axis, we spit out adrenocorticotropin hormone. Well, it's talking to this particular part of the adrenal gland, causing this particular part of the adrenal gland to spit out cortisol. Cortisol, the stress hormone, impacts pretty much all the tissues in your body, but what's mentioned here is the liver, because when we're in the stress state, we actually cause our liver to release more glucose for us. So high cortisol levels often will lead to high glucose levels in the bloodstream because cortisol tells the liver, hey, chop up your glycogen and release it for me. So that comes here from that middle layer of the adrenal cortex, the outer part. The innermost layer is called zona fasciculata, and this particular layer helps to make some androgens. It's a lot weaker than things like the testes or the ovaries, but it can still secrete those as well. So those are my 3 outer secretions. In the very middle, we have what's called the adrenal medulla, and the adrenal medulla is part of my fight or flight system. So it's spitting out epinephrine and norepinephrine. Again, those are going to impact pretty much everything in your body. But when we spit those out, we're doing that fight or flight response. So our heart's going to beat faster, our muscles are going to contract, our liver is going to liberate glucose for us. So another important endocrine organ, the adrenal glands, spitting out these various hormones for us. And then one of the other endocrine glands that we talked about was the pancreas. There's really two main hormones in the pancreas that you need to know. Hormone number one is insulin. So remember when we were talking about it, I told you I like to think of insulin as telling the body's cells, take glucose in. Insulin, take it into my cells. So we're going to spit out insulin. Notice when we have hyperglycemia, meaning we have extra glucose in the bloodstream, that will tell my cells to spit out insulin, which means everybody in the body is going to take that glucose in. If we're in a state of hypoglycemia, we're going to spit out glucagon instead. And remember, I like to remember this as the glucose is gone. And so that's going to go down and talk to places like the liver or the skeletal muscles that store glucose and tell them, hey, spit out that glucose for me. I need some more sugar in my blood. So most of the endocrine system organs, all on that first page. A lot of the hormones we talked about, all on that first page. But a reminder that we did have a couple of others that we talked about with the adrenal glands and the pancreas. Any questions about these endocrine organs? This is the point in the class where I find this one. I just sent you all a cricket. I got some crickets going on. All right. Well, if you think of things as I continue going on here, feel free to put them in the chat. That is the sum of what I wanted to review with you about endocrine system. That pretty much is all of it. I hope you feel like I feel, like looking back on it now, I'm like, oh, okay, I can understand this now. Like it's not quite as scary as it was back in the day. So hopefully you feel a little bit better about endocrine. I think that was one of our biggest words that was on the list. The other one that was definitely one of our biggest words on the list as well was the immune system. So we're going to try to overview what was like 4.5 hours of lecture in about 15, 20 minutes. We'll see how we do. When we talk about the immune system, remember that the goal of the immune system is to keep you healthy. So we have 3 lines of defense that are designed to keep us healthy. We have what's called the first line of defense. And when we're thinking about the first line of defense, a good thing to write down next to it or to make sure that you remember is that the goal of the first line of defense is to make sure that nothing gets into the body. So the first line of defense is things like your skin, the epithelium. It's things like the epithelial lining along your digestive tract, inside your mouth or the vagina. The goal of all of those kinds of epithelium is to make a physical barrier. And then we see throughout places that are in contact with the environment, we're also going to have things like enzymes or acids, normal healthy bacteria in these places, again, trying to make sure that nothing gets into the body. Those are my first line of defense. My second line of defense is going to kick in when something gets into the body. And so some of my second line of defense is what we see here as always on, meaning it's always present, it's always ready to be activated no matter what. And that's going to be things, notice, that are labeled up here as humoral immunity. So by humoral immunity, I mean stuff that's floating around in the plasma. So floating around in the plasma, we've got complement, which is those sets of proteins that stacked on top of each other, made holes and stuff and caused it to die. That's one type of my second line of defense that just indiscriminately kills things that are inside the body. Same thing with inflammation. So we have chemicals that are spit out that when we rupture part of the skin, the inflammation response will kick in. But I'll mention with that inflammation response that we also start to get into our cellular elements of immunity with inflammation, because part of what inflammation does is it calls our neutrophils to the site of a wound. And when we talk about immunity, the first one on the scene, the most generalized, I'm going to be there and start getting stuff done, that's the neutrophils. So the neutrophils follow chemicals that come from an inflammatory response, or if they're floating around in the body and they happen to bump into something that's not good, they're going to try to help deal with it. The other thing that's part of our second line of defense, you're in the body and I want to deal with you, are what we call antigen presenting cells. So antigen presenting cells are cells like our macrophages or our natural killer cells. So these are cells that are going to go and eat up something that's not supposed to be there, a bacterium, a virus, a fungus. They eat it, and then like their name suggests, they do antigen presentation, meaning I found something that doesn't belong here. I'm going to go show it to my big guns, primarily some of these third line of defense things. I'm going to show it to them to get them activated so that they can kick into gear. So when we're thinking about immunity, remember, first line of defense, I don't want stuff to get into the body. Second line of defense, bummer, it got inside. I'm going to try to deal with it very quickly. Third line of defense is my specialized defense. So notice if we're looking at our flow chart here, it says that the third line of defense is a delayed response. Because when we're talking about this delayed response, we have to activate specific cells to cause them to be able to do this kind of response. So while I can start eating stuff up, that's what macrophages do, or while I can start killing cancer cells or other infected cells, like natural killer cells do, I can do that right away, but getting these guys activated takes a little bit of time. So there's two main kinds of lymphocytes that we use in the third line of defense. We use T cells, which have the ability to divide into different cell types for immunity. And we also use B cells, which become plasma cells. Notice that they spit out in a blue box here, antibodies, which are something that circulates in the bloodstream. It's another humoral immunity element. So I activate my T cells, and either they're going to become a cytotoxic T cell, which means it's going to go and kill something that's infected, or it's going to become a helper cell. We use helper cells to help activate other cells involved in immunity. So to help train these cytotoxic T cells, or very importantly, to turn on those B cells. We need helper cells to be able to do that. So the adaptive immune response, it takes a little bit longer, but it's also a very specific response that involves activating these lymphocytes. These guys over here in the second line of defense, non-specific, ready right away. They're going to help us as soon as something gets in, but it may not be quite as good of an immune response. Checking the chat. Yes, there's a great application question here that asks, when we're thinking about these types of immune responses, is this related to our buffering systems that we were talking about? That's an excellent question. We wouldn't change the pH of our body overall to address something that is invading our body just because that'd be bad for everybody. We have the normal pH range that we want to be in. If we get out of that, if we become acidic or basic, that's bad for the entire body and bad for our invader, but also bad for us. That being said, there's a definite possibility if we had, for example, an invader in our lungs, that could mess up with our respiratory buffering system. Or if we had an invader in our kidneys, that could mess up the renal buffering system. So while we wouldn't specifically use internal pH as a means of addressing things, we definitely could see effects of an infection in those places, altering our ability to modulate pH. So yeah, that's a great connection to pull those things together. We talked about our lines of defense. When we're talking about second line of defense that we have here kind of in the purple, or my third line of defense that we have here in green, Remember that we kind of have two main classes of white blood cells that then differentiate into other things. So when we were talking about these things called granulocytes, really the only one we mentioned on the previous page was neutrophils. So remember that neutrophils are my first on the scene. They're really good at dealing with bacteria. They're really good at just a generalized cellular response that's fast. But a quick reminder that we do have other kinds of granulocytes. When we talk about a granulocyte, it gets its name because of the polka dots that are inside of it. So an eosinophil has red polka dots. When you see a red eosinophil, this would be indicative of some kind of parasite. So for example, a parasitic worm is commonly an example that's given. So some kind of large parasite like that, eosinophils would spit out their granules, their little bubbles, to deal with that parasite. Basophils are, when we think about them, primarily if a patient has elevated basophils, they're most likely to be having an allergic reaction because what the basophils spit out in their little bubbles causes inflammation. And if we have too much inflammation, we're probably having an allergic reaction. Our last kind of granulocyte cell are what are called mast cells. And mast cells are basically the same thing as basophils. They don't have those specialized dark bubbles that we see here. But if we're having allergic reactions specifically in a tissue, that's going to be caused by our mast cells. So big picture, granulocytes, cells that have polka dots. They all arise from the same stem cell and have these four different things they could turn into. When we're talking about agranulocytes just means I don't have granules, none of those spots. So there's two kinds of those. There's the lymphocytes, which we've talked a little bit about, and then there's the monocytes, which we haven't talked much about. We're going to go there first. When we talk about monocytes, this is a type of cell that's going to differentiate into my two kinds of antigen presenters. So macrophages are what we call, again, the big eaters. They're circulating throughout the body or throughout your body's tissues, and they're eating things that shouldn't be there. If they eat something that shouldn't be there, they're going to go find typically one of my types of lymphocytes, my specialized cells, to tell it what to look for. When we talk about dendritic cells, same deal. They bump into something that's not supposed to be there. They're going to go take it, do some show and tell. And notice the other kind of antigen presenting cell is something that does technically come from the lymphocyte lineage. And that's those things called natural killer cells. But what's different about a natural killer cell compared to dendritic cells and macrophages is the fact that a natural killer cell is going after cells that have been infected. So it's not eating up a bacterium or a virus and showing that to another immune cell. It's not eating up something else. What it's doing is, you have an infection, I'm going to kill you. You have bacteria inside of you, I'm going to kill you, to ensure that we don't keep replicating and making more of the antigen. So this is another kind of antigen presenting cell, because once it causes a sick cell to undergo apoptosis, it can then take those markers that were on top of it and show it to other lymphocytes. So that brings us to the lymphocyte lineage, very last one. There are two main kinds of lymphocytes. So we've got the B lymphocyte, and anytime you think of a B lymphocyte or a B cell, we're always thinking antibodies. This is my kind of lymphocyte that makes antibodies for me. So when they get activated, we call them a plasma cell. They spit out plasma proteins, antibodies, that will go and tag any of the antigens that are floating around in the body. When we think of the T cells, there are kind of three main lineages they're going to go down. So thing number one that many of them will become are helper T cells. And helper T cells are critical to activating some of our other kinds of cells. If we don't have helper T cells, I am not able to activate my B cells, for example, or I'm not able to as effectively activate cytotoxic T cells. So while they're only activators, they don't actually do the kinds of immune responses, I need them to activate my big guns to break out those cells. Very similar to natural killer cells are those cytotoxic T cells. So again, cytotoxic T cells, they're going after things that where the cell itself has been infected. So typically with viruses, with cancer, these cells will eliminate those kinds of infected cells. We do also have this smaller lineage of T cells that are the regulatory T cells. And you don't need to know as much about them, just that, like their name suggests, they are regulators. So they're going to make sure there's not too much of an immune reaction, those regulatory T cells. Before I move on from this general introduction, do we have any questions about cells or about our lines of defense? Hit me up with a question or give me some kind of emoji. Let me know you're still here. Getting a couple of thumbs up. Perfect. I'm a nerd like this, so I noticed that I've lost a couple of our classmates. I'm just too boring. So, oh well, they're lost. Awesome. Christina, I love it. All right. Well, let's keep going with immunity. I think immunity is probably where we're going to spend the most time, just because it's needed, right? So I'm looking at my slide and I'm like, oh, Dr. Ahles, these two little red lines here, for what it's worth, were supposed to be underneath foreign antigens. So if you are taking your notes, that's what these little red lines were for. It was supposed to be under foreign antigens. And when I made this table bigger, I forgot to move those little lines. So what we're going to talk about now are things called major histocompatibility complexes. I actually had several specific requests in the square cap question asking me to review these. So I'm glad that some of us were thinking about these. They are important for us to know. So a quick reminder about MHCs, major histocompatibility complexes. Big picture, all they are is receptors that are on the surface of all of my cells in the body. So every single cell in the body, one exception being the red blood cells, everybody has class 1 MHC proteins. So everybody has the potential to be showing something outside of them. Now, for the most part, what I'm going to find in class 1 MHC proteins are what we would call self antigens, meaning this is my normal proteins, my normal name tag. I belong here. I'm supposed to be here. That's class 1 MHC proteins. They're supposed to have self stuff in them. If somehow we end up with a foreign antigen in a class 1 MHC, in just a normal cell, so an epithelial cell that's in the digestive tract, for example, if that cell has a foreign antigen, something that's not supposed to be there, that's going to tell the immune system, I've been invaded. I have a virus, I have a bacterium, or I've become cancerous. If there's something wrong in a class 1 MHC protein in your normal cells, that means that cell needs to die. So notice that class 1 MHC proteins, these are going to activate our cytotoxic T cells, the ones that are going to kill cells that have been infected or cells that are cancerous. So a normal cell has the wrong protein in its class 1 MHC. A cytotoxic T cell is going to kill it. If we have an antigen presenting cell, so a macrophage, a dendritic cell, something like that, that's designed to show these kinds of things. If they present an antigen that is not self, and they go up to a cytotoxic T cell with this in their class 1 MHC, that tells the cytotoxic T cell that there is something going on in the body. There is a foreign invader. I'm not sick, but I need you to find any cells that have this kind of marker, because any cells with this marker are sick and we need to kill them. So when we're thinking about class 1 MHC protein, thing number one we need to know is that everybody has them. All of your cells has class 1. So going along with that then, the other thing to know about everybody having them is that normally what's inside a class 1 MHC is a normal self-antigen. It should not cause an immune reaction. If there's something that's foreign, that's in a class 1 MHC protein, it means that we've got some kind of, what they've listed here, endogenous problem. Endogenous, a fancy word for intracellular. I've got some kind of problem inside my cell, making it to be covered in proteins that are not my normal self proteins. So class 1, supposed to be, I'm a normal, happy cell. If things are wrong, that cell needs to die. Cytotoxic T cells will deal with that. We also have a type of MHCs called class 2 major histocompatibility complexes. And when we think of class 2 MHCs, these are only found on antigen-presenting cells. So the only cells that are going to have this kind of receptor on them are things like my dendritic cells or my macrophages. We also see this on our B cells. Remember that B cells become plasma cells. So if they have this here, they're going to not only be able to make antibodies that will tag things that shouldn't be there, they're also able to activate other cells. So I've got an antigen presenting cell. I've got a dendritic cell, like I see over here. This dendritic cell inside its class 2 major histocompatibility complex has something foreign, something that doesn't belong. When it goes and talks to a helper T cell, what it's saying is, I've found something. So I found a foreign invader. Now that invader, because we're in a class 2 MHC, that invader is exogenous. Exogenous means I live extracellularly. So if something's in a class 2 MHC receptor, it's not an intracellular pathogen. It's an extracellular pathogen. And my macrophage found it, my dendritic cell found it, a B cell found it. They're going to take that little bit from that extracellular pathogen. They're going to go show a helper T cell and tell the helper T cell, hey, so there's this stuff floating around outside my cells that shouldn't be here. When a B cell that has this extracellular antigen inside its receptor, when it goes and talks to a helper T cell, that's the moment of what we call double recognition. That's the moment of, hey, B cell, you get to start making antibodies. So if a B cell has an antigen in its class 2 MHC, it goes to the helper T cell and it gets permission to start spitting out antibodies. If a dendritic cell or a macrophage goes to a helper T cell and shows what it's got, that's going to activate the helper T cell to go and find things like cytotoxic T cells to activate and increase the immune reaction. So big picture with my MHCs, there's different kinds of these receptors that we have on different types of cells. We only have the type 2 kind if our job is to be an antigen presenter. Otherwise, we just have regular ones because my job isn't to show off what's wrong. My job is just to exist. These type 2 ones that I only have on antigen presenting cells, they're going to help us to find things that are outside of the cell that are causing an infection, things like bacteria, like we see in this picture. They're going to go talk to a helper T cell, and the helper T cell is going to help us to mount a response that deals with stuff that's outside of the cell. When we talk about class 1 major histocompatibility complexes, if we have a protein in there that shouldn't be in there, that means that we've got an infection. There's something inside me that's causing me to put the wrong protein in what should have been my name tag. So if I have the wrong protein in my name tag, a cytotoxic T cell is going to kill me. Unless I'm an antigen presenting cell, in which case that's going to activate the cytotoxic T cell to go find others that are infected. I just said a whole lot of stuff. I need to pause for a moment and give you a chance to process and to ask me any questions that you have about these MHCs. Excuse me. Great question in the chat. The question is, do antigen-presenting cells have type 1s and type 2s? That is correct, yes. So they will have a place with their normal antigens in it, and then they will have a place for the antigens that they found in the environment. So that's actually a great kind of application or next step thing to think about. If I have an antigen-presenting cell that has been infected with something, that antigen-presenting cell most likely would present some of those antigens on its class 1 proteins as well, because it has something inside of it that's causing a problem. So short answer, antigen-presenting cells, yes, they have both types of these proteins. I'm curious, talking through it now, this time, how many of you feel a lot better about it now than you did before? Does anyone else feel a lot better about it? I feel like now, you know, like 4 months after we first learned it, I'm like, oh, I got this now. These MHC things, they were real tricky at the beginning, but I think they're a lot less bad, put it that way. All right, let's move on. There is something that we do with our lymphocytes, our specialized cells, to ensure that we don't get reactions to ourselves and to ensure that we can actually have reactions, period. So the two things that I do with my lymphocyte cells are what we call self-recognition. Self-recognition means if I want to show you something in a major histocompatibility complex, can you recognize that I'm trying to show you something? That's self-recognition. If you can't recognize that I'm trying to show you something, you're not helpful for me, and I need to get rid of you. So step one, when we're talking about T cells, and we'll talk about this kind of with B cells as well. Step one, you have to be able to interact with an MHC receptor. So if I can't show you anything in an MHC receptor, I don't need you. But then step two is when I show you something in an MHC receptor, if that something is me, does that activate you? So if I have a T cell that, yes, it can read major histocompatibility complexes, awesome. But when it reads them and it sees a protein that belongs to me, if that completely activates it and it gets really excited, it's going to go and kill self cells. That's not a good idea. So we learn both self-recognition, can you read major histocompatibility complexes, but we also check for self-tolerance. We want to make sure that you're not going to do an immune reaction against me because I don't need to be destroyed. I am your cell. So that's what brings us to what we talked about with how we make specialized T cells and specialized B cells. We make them using both what we call positive selection and negative selection. So when we first start developing T cells, at the very beginning of T cells, we're looking to see, can you actually read what's inside a major histocompatibility complex, an MHC? If you can read an MHC, that first step there, positive selection, if you can read it, awesome. You're going to get to keep developing. If you can't read an MHC, if you can't plug into that receptor, you're useless to me. I'm going to eliminate you. So notice I've got a little note here in the box. If I can't recognize an MHC, I'm not doing what I'm supposed to do. I'm going to be gotten rid of. I can't stick around. I'm not doing what I'm supposed to. But then I need to check for self-tolerance. So when I have a T cell receptor, if that T cell receptor is activated by self-antigens, I will either get rid of it, I'm going to delete it because it's auto-reactive, it'll attack me, or I'm going to put it in a state of anergy. So if I put a T cell in anergy, that means I need to try to fix you before I release you in the body. So these two examples are examples of T cells that are doing something that they're not supposed to do. Because they're doing something they're not supposed to do, I've got to get rid of them. My cells that can do what they're supposed to do, awesome. You get to stick around, you're good. So in T cells, we start with, can you actually read an MHC? If you can, awesome. Now let's make sure you don't read me as foreign. If that's the case, you're good. When we talk about B cells, we do things a little bit differently. When B cells are developing, they actually kind of start with the self-tolerance thing. So if you remember, B cells are often covered in antibodies on their outer surface. So we check those antibodies and say, hey, here is myself. Here's a self-antigen. Does that make you react? If you react to a self-antigen, you're doing something you're not supposed to do. I need to get rid of you. If you don't react to a self-antigen, awesome. Then we get that first signal. So remember how we talked about the B cells are floating around. If they bump into an antigen that's outside the body, when they attach to it and they go to try to find a T cell to do this co-stimulation thing, if they get co-stimulated, awesome, we're going to mount an immune response. But if they never get co-stimulated, if they try to find a helper T cell and they just can't, if that's the case, either they're going to get inactivated or I might eliminate them. So to some extent, we do it backwards with B cells, but the big picture is always the same. I don't want to respond to myself, but I do need to be able to respond in general. Self-recognition, you can read what's going on. Self-tolerance, you're not going to react against me, against myself. So here's how some of these cell lines work, or the way we kind of bring things together with the T cells. And we'll show the B cells on the next slide. Remember that T cells and B cells start in the bone marrow. And when we're talking about the T cells, they go to the thymus. That's how they got the letter T. When they're in the thymus, they're going to have one of two different kinds of receptors. Some of them have the CD4 protein receptor, and that protein receptor dictates that they're going to be able to read class 2 MHCs. And if you're taking notes with me, underline, highlight, star class 2 MHCs. If I have a CD4 receptor, I'm going to be able to read class 2 MHCs. And here's a friendly reminder for us that if I'm reading a class 2 MHC, I'm reading stuff that's from an extracellular pathogen. So this is a bacteria, this is a fungus that's floating around in the bloodstream. That's what we see in type 2 MHCs. So if I can read those with my CD4 receptor, there's two options for what I'm going to be. Option number one is I'm going to become a helper T cell. If I become a helper T cell, my goal is going to be to help activate my B cells. I can also become a regulatory T cell to make sure that I don't have too much of a reaction. And remember, when we're talking about the adaptive immune system, what is kind of the best about it is that we make these memory cells as well. So I'm in the thymus, I have a CD4 receptor. That receptor plugs into class 2 major histocompatibility complexes. Those are full of antigens that came from things that are outside of my cells. I'm going to help activate B cells, or I'm going to regulate, make sure that I don't over-attack parts of my body based on being exposed to this. That's if I have CD4. The other option for a T cell is that it's going to have the CD8 receptor. And if it has the CD8 receptor, underline, highlight, star, we're doing class 1 MHCs. So remember that class 1 MHCs, these were the ones that were full of intracellular pathogen stuff. So viruses or fungus or stuff that's inside a cell. So if I'm a CD8 cell, I can be activated by antigens, by things that are inside my cells. And if I can be activated by what's inside my cells, I'm going to need to be a cytotoxic T cell, because to kill what's inside the cell, I need to kill the cell that's infected. So this CD4 thing and CD8 thing, it tells me which kind of major histocompatibility complex can I actually read. If I know what kind of antigens I put in each of these kinds of major histocompatibility complexes, that can give me an idea of what I'm going to become. Because if I'm looking at intracellular antigens, I'm going to have to deal with that intracellularly by killing the cell. But if I'm looking at antigens that are extracellular, then I can become a helper cell and get my B cells on it, make them get activated. That's kind of the big difference with CD4 and CD8. So let's bring in those B cells then. We've talked about this left side of the picture here. So we said that T cells start in the thymus. Then as they mature, as they're exposed to things, we do the self-recognition and the self-tolerance. Now we're floating around in the body, and we've got some that are CD8 proteins, cells that have the CD8 protein. Those are my cytotoxic T cells. Remember, they go out and they kill cells that have an intracellular pathogen. But over here on the right, we've got those helper T cells. These were the ones that had the CD4 protein. These guys are activated by extracellular pathogens. So here comes my helper T cells. My helper T cells make themselves a clone army, and then those helper T cells are going to interact with the B cells that attach to the same thing. So I've got in an MHC2 complex over here, I've got an antigen that also this B cell receptor also gets activated by. When we talk to each other and say, hey, look, we're both responding to the same thing, that causes these immature B cells to get activated and become plasma cells. And when they're plasma cells, they can spit out a whole bunch of antibodies that are going to circulate through the bloodstream, and they're going to go kill bacteria or viruses, things that are outside of the cell. So friendly reminder for us, we need helper T cells, 2 reasons. Reason number 1, because I must have them for B cells to get activated at all. B cells will not get activated without a helper T cell. The other thing, though, when we're over here on the cytotoxic side, I need to have helper cells to create a memory component. So when we're talking about cytotoxic T cells, if I don't have the T helper cells to work with them, they're not going to make memory T cells. And then the next time I encounter that antigen, it's going to be just like the first time. So I need helper cells to make memory, and I need helper cells to make antibodies. Without those helper cells, I can't do it. Yay for B and T cells, right? Let me pause, and I'm going to check out my chat, see what questions we have about these. Oh, that's the question I answered already. What other questions do we have? Try to find us something. Here's how I felt when I was looking over some of this stuff today. Is co-stimulation by the MHC for B cells? Okay, so great question. For B cells to get activated, they need to do that thing called co-stimulation. So when we talk about co-stimulation, this CD4 protein down here, this is actually what co-stimulates the B cell. So the B cell is going to have an antigen inside its receptor. So we've got the antigen right here. Along comes my helper T cell with its major histocompatibility complex. We attach to the antigen right here. And while we're attaching to it, that CD4 protein goes down to the B cell. Think of it kind of like patting on your dog. Here's your little hand that's saying, good boy, you found something. So the CD4 protein is what's going to co-stimulate the B cell, because both the helper T cell and the B cell have recognized the same thing. Because they both recognize it, that CD4 protein says, okay, I'm giving you permission, make some antibodies. So it's not the MHC that co-stimulates the B cell. It's going to be that extra protein on the helper T cell. If you're still with me, shoot me a thumbs up or a smile or something. Yeah, so a follow-up question, co-stimulation and linked recognition being the same thing. For the purposes of our studying, we're gonna say yes. Yeah. So linked recognition, another way that those have to interact with each other. So we need that interaction for them to be able to be activated. So yes. Awesome. Thanks for the high five, Jocelyn. I love it. High five back at you. All right, let me see. Okay, that's what I thought. Look at that, guys. Immune system in like 20 minutes. What took us, what, like 6 hours? We tried to get it here in 20, 30 minutes. So that's not too bad. I'm getting a lot of positive feedback in the chat. So I'm hoping that means we're feeling maybe a little bit better about these things. Obviously still studying to do, but hopefully this is a little bit helpful for us. Two other most common things that I saw in the SquareCap chat was related to the urinary system and the respiratory system. So I'm going to try to do an overview of some of the important parts of both of those systems. I'm not going to hit them quite as in depth as we did some of the other stuff, but I do still want to hit some of kind of the most important ideas. So when we're talking about the urinary system, really the biggest part of that we're going to review is this process of forming urine. So the process of forming urine takes 3 different steps. So the first step is glomerular filtration. When we talk about glomerular filtration, I very purposely underlined this in yellow because in glomerular filtration, the stuff that's inside the bloodstream goes into my nephron. So kind of like urine is yellow, we're dumping stuff into urine. That's glomerular filtration. Always stuff is leaving the blood vessels. When we're doing the processes of tubular reabsorption, we are bringing stuff out of my tubules, the proximal and the distal, as well as a little bit here in my nephron loop. I'm pulling stuff out and I'm putting it back into the bloodstream. So a friendly reminder, because I know that this messed with my mind. If I'm doing reabsorption, what's actually going to happen is the amount of that thing that I'm reabsorbing in my blood is going to go up. So if I reabsorb, for example, water, I do a bunch of water reabsorption here. That means that I'm getting water back into my bloodstream. If I do the opposite, tubular secretion, what secretion means is that was in my bloodstream, but now it's going back into the urine. So as we're thinking about these processes, you may have totally gotten that down, and that might not have been an issue for you. But for me, I sometimes got mixed up. If I reabsorb, the amount of this in the urine goes down, but the amount of it in the body is going to go up. If I secrete something, the amount of it in the urine goes up, the amount of it in the body goes down. So when we're looking across the glomerulus, every single part, we can do reabsorption back into the bloodstream or secretion back into the urine formation process. By the time we get to the end of the collecting duct, now we've officially made urine, and that urine is going to have the waste that we no longer need from the body. The process of glomerular filtration, what we do at the very beginning, that process depends on multiple different pressures. And so we talked a little bit about these pressures, but I want to remind us, the first pressure that influences what's going on inside the glomerulus is what we call glomerular blood hydrostatic pressure. So this hydrostatic part tells me that this is a water thing. Glomerular hydrostatic pressure is the pressure that's placed by the water that's inside the blood vessels, pushing that water out. This pressure, I'll mention for you, is the highest of all the pressures that we see in the glomerulus. So it's pushing water out of the blood vessels into this capsule, into the cup that collects it. In a moment, we're going to talk about how we change the glomerular filtration rate, and changing this pressure right here is really the main way we do it. If we make this higher or lower, that's going to cause fluid to go out slower or more quickly. So my first pressure, glomerular hydrostatic pressure, the pushing pressure of water in the blood vessels. Pressure number 2, capsular hydrostatic pressure. Since we're hydrostatic, this is still going to be water. It's still going to be a pushing pressure, but this time it's a pushing from inside that cup. So this pushing pressure is all the water that's leaked out that wants to push to go back into the blood vessels. So this is going the opposite direction of this. Capsular hydrostatic pressure, opposite of glomerular hydrostatic pressure. And the one last kind of pressure that we're concerned about with the glomerulus is what we call blood colloid osmotic pressure. This colloid thing means proteins. So blood colloid osmotic pressure is the pulling pressure. The amount of proteins that are here inside the blood vessel is way higher than the amount of proteins in the capsule. Theoretically, there's not supposed to be any proteins in the capsule if we're doing our job right. So plasma proteins that are here inside this blood vessel are trying to pull water back inside. That's this last kind of pressure, blood colloid osmotic pressure. When we do filtration, it's a combination of all of my pushing pressures and my pulling pressures. My pushing pressure of the water, that's the only pressure I have that's trying to get things out of the blood vessel. My pushing pressure from inside the capsule and my pulling pressure that's inside the blood vessel, both of those are trying to slow this process down. So keep in mind, my one pressure that tries to help with filtration is the glomerular hydrostatic pressure. These other two are trying to slow down that process. They're trying to prevent it. We talked about multiple different ways to regulate the process of glomerular filtration. So some of those regulation mechanisms were all by itself inside the glomerulus. We call it intrinsic. So intrinsic means that nothing outside of the kidney has to be activated. So my first way to change glomerular filtration rate that's inside the kidney by itself is called myogenic. Myo means muscle. So if I'm chilling out in the kidney and all of a sudden this afferent arteriole, the blood vessel that brings stuff into the glomerulus, if this gets super stretched out, that blood vessel is going to say, whoa, wait a minute, too much coming in right now. I'm going to contract the muscle inside of my vessel, and that's going to slow down how much fluid's coming in. So by decreasing the volume that's coming into the glomerulus, this mechanism is going to decrease the rate of urine formation. If we're all stretched out here, slow it down so that we don't dump too much stuff out in this process of filtration. The other intrinsic thing that stays just inside the kidney is what we call the tubuloglomerular feedback mechanism. The tubuloglomerular feedback mechanism is regulated by these guys right here, called the macula densa. So the macula densa is a group of cells that we see. They're kind of right next to or in between the distal convoluted tubule and my two blood vessels that I see here going into and out of the glomerulus. So if my macula densa cells are checking out what's going on here in the distal convoluted tubule, and they're like, wait a minute, there's way too much salt here in this distal convoluted tubule. What that tells them is that the urine is being made so fast that we can't reabsorb enough of that salt. So if we detect a bunch of salt in the distal convoluted tubule, what the tubuloglomerular feedback mechanism will do is change the amount of nitric oxide that is present or being released to the afferent arteriole. As that goes down, this afferent arteriole actually contracts. Again, it's a contraction. So as we make this smaller, the amount of fluid that's going to the glomerulus goes down, the rate of filtration goes down, hopefully to allow us to catch up and reabsorb everything we need. So both of these mechanisms ultimately are messing with the afferent arteriole. They're making it smaller. If I make it smaller, that glomerular pressure, the hydrostatic pressure, goes down. I don't make as much urine. Those are my two, I'm inside the kidney, I don't need anything else methods. I also have a couple of extrinsic methods that just work on the afferent arteriole. So one of those methods is when the sympathetic nervous system kicks in. When the sympathetic nervous system kicks in, the fight or flight system, when that kicks in, that's going to cause this afferent arteriole to get smaller. Again, if we're in fight or flight, we do not need to be making as much urine, so we'll slow down glomerular filtration. When we do that, when we contract that afferent arteriole, that's going to lead us to not make as much urine. So sympathetic regulation, again, changing that afferent arteriole. And the afferent arteriole is actually the same place that atrial natriuretic peptide has an effect. So atrial natriuretic peptide, friendly reminder that this is something that we release when either the blood pressure is too high or that's indicative for us of the water levels being too high. So atrial natriuretic peptide talks to the afferent arteriole. But this time when it talks to the afferent arteriole, it actually causes it to dilate. It makes it bigger. If I make this bigger, if I make more fluid come into here, that's going to increase the pressure down here in the glomerulus. And if I increase that pressure, more fluid is going to leave. So this is the only one here on my list of mechanisms that actually makes the process of filtration go faster. So ANP, atrial natriuretic peptide, is going to cause me to spit out more water to make more urine. And that's because, again, this one's triggered when there's too much water in the body. One final mechanism that we talked about, changing the way the kidney works, is that renin-angiotensin-aldosterone system, RAA. Specifically, though, this hormone angiotensin has an effect on blood vessels systemically. So when we're looking at it here in the glomerulus, when I have high levels of angiotensin, that actually causes both of the arterioles to constrict. So as both of the arterioles constrict, I'm not putting as much blood in, but at the same time, I'm also not letting as much blood out. It becomes harder for the blood to leave, meaning I still have pressure in here that's making some, but not as much urine as usual. So when we're studying how to change urine synthesis, both myogenic regulation and tubuloglomerular feedback, they're self-contained. They're just inside the kidney. These other factors are going to come from outside the kidney, but still have an effect. Most of them changing that afferent arteriole that brings blood in. A couple of them, or this one in particular, angiotensin, changing that efferent arteriole, and tubuloglomerular primarily acting through the macula densa. Let me pause for a moment. Do we have any questions about this? Regulating glomerular filtration or those pressures? I love, Pamela, that I'm just like blowing your mind. I love that that's the emotion you send me whenever I ask. That makes my day. Love it. All right. Let me take a peek really quick because we're running out of time. Let's see. The only thing I want to talk about on here, since we're a little short on time, I just want to remind you about what happens in the nephron loop. Remember that in the nephron loop, this is that long thing that goes down into the medulla of the kidney and then comes back up when we're making urine. Right next door to this tube that goes down and then back up, right next door to it, we have a blood vessel called the vasa recta. And the fluid in the vasa recta is going the opposite direction of the fluid that's in the nephron loop. So as I'm making urine that goes down and then comes back up, notice that it's coming back upside is when we're in the blood vessel that it's going downside, and then it's coming back up on the other side. This allows us to say, so I've got the fluid right here. The fluid that's right here is maybe 500 milliosmoles. And next door to it is this pre-urine that's 300. And the pre-urine says, oh, you're 500. Let me give you some of my water to dilute you. But then as it gave up its water and it goes down a little bit, now it's at 600. And it notices next door, oh, you're at 900. Let me give you some of my water to try to dilute you. And it goes down further and it's more concentrated. And it says, oh, you're at 1200. Let me give you some of my water to try to dilute you. So as the urine is being made, as it's going down, it's constantly giving its water away to try to dilute what's happening in the vasa recta. But then as the fluid starts to go up, water cannot leave the ascending loop, the ascending limb of the nephron loop. So now we've got this problem where I'm concentrated, I'm 900, and I get over here and you're only 600. And I'm like, well, shoot, I'm more concentrated than you. I can't steal your water. Water's not going to come in. But what I can do is I can get rid of some sodium chloride. So we see as the fluid is moving up in the nephron loop, what it's doing is it's actually pumping out, remember, this uses energy, pumping out sodium and chloride to try to match what's going on next door in the vasa recta. And as we start pumping out this sodium and chloride, that sodium and chloride says, ooh, this water next door in the blood vessel isn't as concentrated as me. I'm going to sneak inside. And so then the pre-urine goes up a little bit more, but what it's looking at is vasa recta fluid that's 500 and it's 600. It says, oh, let me give you some salt. And so it takes that salt and it becomes more concentrated, and it takes this salt and becomes more concentrated. So as we get down into the vasa recta, the blood is becoming more concentrated, and then it's less concentrated. On the descending side over here, it's because water is going in. On the ascending side over here, it's because salt is coming out. So when we're doing this loop of Henle thing, it's all about managing or balancing water levels and salt levels. Remember that when we're in the descending limb going down, water can move. When we're in the ascending limb, the only thing that can move is sodium chloride. I cannot do any water exchange at this point. And remember that normal in the body is that the collecting duct cannot reabsorb water. That's normal times. If we spit out antidiuretic hormone, that's the only way we can actually absorb water there. So again, normal times, nothing being absorbed in the collecting duct, only when we have that antidiuretic hormone. And hey, let's tie it all together. Remember that antidiuretic hormone is made by the posterior pituitary gland. And remind me in the chat, posterior pituitary gland does or does not make its own hormones. Does the back half of the pituitary gland make its own hormones? Does it make its ADH? Yeah, it does not. That's absolutely right. So antidiuretic hormone, while it's released from the posterior pituitary gland, it is not made there. It's made in the hypothalamus. So keep that in mind. You have this picture in your notes. I'm not going to spend a lot of time on it. What I'll mention for you, again, this was what I was going to highlight today. When we reabsorb something, it's going back into the bloodstream. When we're secreting something, it's going to end up in the urine. Let me check my learning objectives really fast. Okay. We do have a learning objective that asks you to know where things are or are not reabsorbed or secreted. So let me just highlight for you a few things that I think to make sure we know, because we're at that point in the semester, right, where it's just like, we can't learn it all. So here's what I want you to make sure you know. Make sure you know that the primary place we reabsorb water, proximal convoluted tubule. Water is the primary place, or excuse me, that water is reabsorbed primarily in the proximal convoluted tubule. I can do some of that reabsorption in the descending limb as well. Those are places in normal times that I do that reabsorption. I can only reabsorb water in the collecting duct if I have antidiuretic hormone. That's what we just talked about. So without antidiuretic hormone, water is done. It's not moving after that descending loop. I want you to make sure that you know that the distal convoluted tubule, as well as the collecting duct, are locations where we do a lot of sodium reabsorption. But why I want you to know that is because those are the places where aldosterone from that renin, angiotensin, aldosterone system, this is where aldosterone acts. So the distal convoluted tubule and the collecting duct, I want you to know that that's where sodium is reabsorbed. It's coming back into the body when we have aldosterone present. I also want you to know that aldosterone helps us to secrete potassium as well, get rid of potassium. Because remember, aldosterone was the exchange. So sodium comes back to me, potassium leaves. This is going to happen because of aldosterone. So focus primarily on those things. The one other thing I want to add right here, I want you to know that the ascending limb of the nephron loop, we can only do salt there. So sodium, potassium, and chloride. I can only do those on those. That's this side. That's what we talked about. There's no water reabsorption here, just the salt on this side, just the water on the other side. Make sure we know those things. I'm not going to review this with you because it's literally straight from your slides, but just be aware that there's a lot of stuff we should not have in urine. If we have that in urine, that can be problematic for us. So we've talked now a little bit more about pH buffering stuff, so this should make a little more sense for us. Your urine does run acidic compared to your blood pH, but we don't want it to run too acidic. That might indicate that some things are out of balance. What I briefly want to take, oh yeah, let me pause for a moment. Shruti asked to talk about specific gravity. So I'm going to be totally honest with you. That I don't think is one that we're going to ask you about. Let me check to confirm that. Was it something that they asked you about on the lab exam?
Yes, Dr. Ahles. There was plenty of questions about specific gravity, and I genuinely didn't know what to talk about it in the lab. They had like 4 to 5 questions based on the specific gravity.
Wow. Okay. Well, so here's what I'll say. It won't be on the lecture exam, but here's what I'll say when we're talking about that for lab purposes. Specific gravity gives you an idea of how much stuff is dissolved inside the urine. So as the specific gravity gets a little bit higher, that can kind of be an indication of other stuff that's out of balance. And let me make sure I have, let's see. Yeah, so basically, I just did a quick search to make sure that that's what it is. So if I have a really high specific gravity, I'm expecting to find more of these kinds of things that we were looking at inside the urine. Lower specific gravity, normal range, going to be right around that 1 or this very low range, because there's not supposed to be a lot of particulates in the urine. If I have more particulates, gravity is going to have a higher effect, and that's going to mean I should probably keep looking for other things as well. So I'm sorry that that was a major part of your lab exam. I was not aware that that would be a major part. So I will make sure for future semesters to chat about that with my students. I do apologize about that. Let me check my questions. A question, most water reabsorption occurs mostly in the proximal convoluted tubule. That would be correct. Most of the reabsorption of water starts here. The rest of the normal reabsorption that doesn't require hormones would be in this descending loop. If I'm going to do any reabsorption in the collecting ducts, I have to have hormones to do that. So proximal convoluted tubule, descending loop, that's the only places I normally reabsorb water without help. Okay, and so Madeline mentioned that there was some resources in the lab module that mentioned stuff about specific gravity. So that's good to know as well, that those resources there. I'll definitely look into that for my students next semester. All right, here is briefly what I want to mention for you with respiration. Make sure you remind yourself that there are many structures in the respiratory system that don't do gas exchange. That's the conducting zone. The respiratory zone is the ones that do actually do gas exchange. So that's really just the respiratory bronchioles and then those little sacs that are down there. That's all I included this for, is to show you the difference between conducting and respiratory. Make sure we know that these are our only respiratory structures where we can actually do gas exchange. We do what's called pulmonary gas exchange. That's getting oxygen into your bloodstream. We do that at the respiratory zone with the alveolar sacs. And then we will do systemic gas exchange down at the tissues. Systemic gas exchange is oxygen goes into my cells and carbon dioxide comes out of my cells. So two different kinds of gas exchange that we do, whether we're just getting it into the body or whether we're getting it into our cells. The three parts of respiratory pressure I wanted to mention to make sure we're clear on that. There are three things that either help or hurt the process of respiration in your body. So the first thing is how much pressure there is, atmospheric pressure. So this is the pressure just from day-to-day living in our environment. Atmospheric pressure, its goal is to push air into your body. We also, though, have a couple of pressures that are kind of pushing air out of the body. So intrapulmonary pressure is the pressure from oxygen that's actually inside the lungs. This pressure, when it's highest, will help with the exhalation process or the expiration process, depending on how you talk about it. And intrapleural pressure is actually a pressure that helps to prevent the lungs from collapsing. So if you notice, inside the lungs, there's a pressure of 760, whereas inside the pleura, there's a pressure of 756. So intrapleural pressure is actually kind of like a sucking pressure that helps to keep the lungs inflated. If we puncture this pleural cavity with a knife, for example, and this pressure goes up, if this pressure gets higher than intrapulmonary pressure, we will actually force the lungs closed. So in normal times, its job is, it doesn't really influence respiration so much as it just keeps the lungs able to receive air. If we have an imbalance with it, it will cause the lungs to collapse and force all of the air out of the lungs. Not really going to talk about those capacities for sake of time, because I do want to take just a little time to talk about oxygen saturation. So when we talk about the oxygen saturation curve, really all this shows is when I'm in these different conditions, how many of my hemoglobin proteins are attached to oxygen and how many of them are not. So when I'm in a situation where there's a whole lot of oxygen, I would expect most or all of my hemoglobin proteins to be attached to oxygen. When I'm in a situation where there's not a lot of oxygen, I would not expect there to be a lot of oxygen attached to hemoglobin. So throughout the human body, we have very low oxygen pressure, for example, in the body's tissues, and very high oxygen pressure in the lungs. When blood leaves the lungs to go out into the body, it slowly starts to give its oxygen away to parts of the body until it gets all the way down to the tissues and it has no oxygen left. at which point we'll send it back to the lungs, we'll do respiration and reoxygenate it again. So when we look at these curves, that if you're like me, you hated them, but we'll try to make them a little better. There are various conditions that can change how much hemoglobin gets to attach to oxygen. So in black here, we see our normal curve, and that's true over here as well, normal. When we change things, for example, like the amount of carbon dioxide that's in the blood, when there's a lot of carbon dioxide in the blood, that's an indication to me that the tissues of my body have made a lot of carbon dioxide. They're dumping their carbon dioxide into the bloodstream. And that causes two things to happen. Thing number one, when I'm dumping carbon dioxide into the bloodstream, some of that carbon dioxide is going to attach to my red blood cells, meaning these red blood cells can't attach to oxygen because they're tied up with carbon dioxide. That's one reason the amount goes down. The other reason that the oxygen saturation on hemoglobin goes down is because when my cells are spitting out so much carbon dioxide, that means they need more oxygen. So if I have a lot of carbon dioxide, that tells me that my cells of the body are stealing all of the oxygen from hemoglobin. I see that the amount of oxygen attached to hemoglobin is not as high because most of that oxygen is getting given away. So that's what our text here says. When I don't have a lot of carbon dioxide in the blood, I don't have to give away my oxygen as much. When I have a lot of carbon dioxide in the blood, I'm giving that oxygen away. When we talk about pH, here's how we bring in our buffering systems. When I have a really low pH, this is actually also an indicator that I have really high carbon dioxide. Because remember, carbon dioxide can turn into carbonic acid, acid as in dropping my pH. So if my pH is low, I probably have a lot of carbon dioxide floating around, and having a lot of carbon dioxide floating around means that I need to give more oxygen to my tissues, or my hemoglobin is going to have less oxygen attached to it. So this curve going down means that I'm giving away more oxygen, or compare that to what we see up here. If my pH is higher, notice that hemoglobin holds on more tightly to its oxygen because it's a more basic pH. The one other measure that we specifically talked about changing how much the hemoglobin is attached to oxygen is temperature. And I just want to mention for you, if the body is at a high temperature, that means that we're doing respiration really quickly, which means number one, I need a lot of oxygen to go into the tissue. And number two, I'm spitting out a lot of carbon dioxide. Both of those factors makes my hemoglobin saturation lower than normal, meaning the hemoglobin proteins don't have as much oxygen as I would normally expect. So we've got this big scary graph here, and if you don't like it, you don't have to use it. All this tells me is if I have a right shift, so if my curve goes over to the side, that tells me I have a decreased affinity for oxygen, or in other words, I'm giving all my oxygen away. So if there's a lot of carbon dioxide, I'm giving my oxygen away. If we have an acidic pH, I'm giving my oxygen away. If the temperature is too high, I'm giving my oxygen away. All of these things make my red blood cells give away oxygen. When we look at our options here for the left shift, this means I'm keeping all of my oxygen. So if the pressure of carbon dioxide is low, I'm going to keep my oxygen attached. If the pH is high, if I'm basic, I'm keeping all of that oxygen. If my temperature goes down, if it's cold, I'm keeping all of that oxygen. So this graph helps us to get an idea of the factors that would increase or decrease the amount of oxygen that's attached to hemoglobin. Big picture, that's what I want you to know. I don't need you necessarily to interpret graphs, but I do need you to know how carbon dioxide and pH and temperature affect hemoglobin saturation. That was super fast. Can we think of any questions? Do we have any specific questions about this stuff? How many of us are still awake? Anybody? Every time I look over at the class count, it keeps decreasing because I'm talking too long. I know. No questions right now. Perfect. Okay. Two last things I want to mention for you. One of them, you do have the slide. The other one, I forgot to put it in. So this is actually something that I think we had this in our respiratory PowerPoint. So this itself should not look new. But as we're thinking about it, now that we've talked about buffering, this is going to make a lot more sense. So check this out. I'm inside the human body, and inside the body, I suddenly have a bunch more carbon dioxide. When we talked about buffering, we said as carbon dioxide builds up, we start to make more carbonic acid. And if we get too much carbonic acid, that's no good. We don't want a bunch of carbonic acid in the body. It's going to make our pH go too low. So we've got receptors in the body that are constantly monitoring how much carbon dioxide do we have in the blood. If we have too much carbon dioxide, the medulla oblongata says, ooh, we got to deal with this. And the way that the medulla oblongata deals with this is it causes you to breathe more quickly. When we breathe more quickly, remember that every exhale is getting rid of carbon dioxide. So when we detect that there's too much carbon dioxide, if I don't fix this, my pH is going to be off. So I'm going to breathe a little bit faster to get rid of some of that carbon dioxide to keep my pH flat. If I'm breathing fast for too long, now my carbon dioxide levels might get too low. And remember, if my carbon dioxide levels get too low, I'm going to start chopping up my carbonic acid. And if I chop up my carbonic acid, I'm going to become basic. My pH is going to go up. So when I start to run out of carbon dioxide, those same chemoreceptors say something's wrong. We need to slow down the breathing rate. Because if we slow down the breathing rate, more of that carbon dioxide stays in the body. And as it stays in the body, we can use it to maintain homeostasis, to have enough carbonic acid. So when we're thinking about respiratory rate, why would we breathe faster? Why would we breathe slower? It all ties back into what we were talking about with pH buffering. If I don't have enough carbon dioxide, or if I have too much carbon dioxide, those things are going to mess up my pH, which is why I have to regulate the process of respiration. That brings us to the slide that I did not give you. I gave you a slightly different table that after talking with a few of you, I was like, yeah, that was probably more challenging than I thought it was going to be. So this is a very simplified table that shows you how do I diagnose a patient with each of these different disorders. So remember how we talked about in class, we've got acidosis and we've got alkalosis. We've got respiratory versions and metabolic versions. We've already talked about the fact that if a patient has acidosis, that means their pH is low. If they have alkalosis, their pH is high. We've established that. But remember, when we were talking about how do I figure out if it's respiratory or metabolic, I told you what you're looking for is it something wrong with carbon dioxide, or is it something wrong with bicarbonate? So there were some quiz questions, there were some test questions that asked about this. And I apologize, I probably didn't cue you up quite right for it. If a patient is in respiratory acidosis, meaning currently their pH is too low, they haven't tried to fix it yet, that's why their pH is low. If they're in respiratory acidosis, what I'm going to see is that the respiratory buffering system didn't work right. That's a problem with carbon dioxide. So they'll have a bunch of carbon dioxide in their bloodstream, but their bicarbonate levels are normal. Here's why bicarbonate is normal. Because if I raised my bicarbonate, that's how I'd fix this. If I raised my bicarbonate levels, that would mean I'm not at acidosis anymore. That would mean I got back to balance. So the questions talked about pre-compensation, or before, in the case of respiratory acidosis, before the kidneys try to fix things, all we're going to see is a low pH and a high amount of carbon dioxide. We're not going to mess with bicarbonate yet because we haven't fixed it yet. So when we're looking at metabolic acidosis, remember that when it's metabolic, the issue is going to be in the bicarbonate category. So we're acidosis, my pH is too low. And when we're thinking about the basic bicarbonate, I'm going to have too little of my bicarbonate. When I get rid of bicarbonate, I become more acidic. So in a patient in metabolic acidosis, they don't have enough bicarbonate, which means their blood pH is too low. They're too acidic. But their carbon dioxide levels are normal because the respiratory system is just doing its normal job. Now, if the respiratory system kicked in and it was trying to compensate for or fix acidosis, then I would have extra carbon dioxide. But that's after compensation. And remember, if I compensate, I'm not at acidosis anymore. I'm back to normal. So when we're talking about these things, only one or the other will be changed. They won't both be changed. In a respiratory problem, respiratory acidosis, lots of carbon dioxide. In respiratory alkalosis, too little carbon dioxide. Normal bicarbonate. Bicarbonate's not the issue here. In metabolic acidosis or alkalosis, that's going to be a problem either with too little or too much bicarbonate. My CO2, normal, because that's not what got me to these different states. So again, when we're thinking about those kinds of questions, consider that. Metabolic or respiratory, that's going to tell you which one is wrong. The other one is going to be normal unless we're compensating. And if we compensate, that gets us away from being in alkalosis or acidosis. Does that clarify it a little bit more? I know I didn't quite cue that up as well as I wanted to. Yes, there was a question, will you be able to email me? Absolutely. I'll do my best to be on top of my emails. I'm working through where I'm behind now, so you're welcome to email me. I will try to get back to you as soon as possible. Amy asked about the structure of the final exam. It's probably going to be a mix of the kinds of questions that you've been seeing. So don't expect it necessarily to be all multiple choice. There might be some drop-down menus or some matching or that kind of stuff. Diana asked about the number of questions. I suspect 100. That's pretty typical. Madeline asked about the timing of the exam. Because all of the AMP2 classes are taking it around the same time, I can't necessarily open it up much earlier. But if you want to get in touch with me, I might be able to wiggle to Monday afternoon, if that would help. All right. Well, I appreciate all of you chilling out with me. Here, let me give you something as your little reward here. Listen, I'm going to add a new slide. Since you all are awesome and you stuck around with me to the very bitter end, I'm going to draw you a penguin because that was one of my favorite things to do with online classes. So you all stuck it out to the very bitter end and you get an anatomy penguin. And he believes in you. You can do it. I'm holding a little sign for you. All right. Well, I know I kept you way longer than I expected to. Again, I appreciate that you all stuck around. I know it was very long. But if you have any questions for me, I'll chill out in the chat for a little bit. I will work on getting this posted if you want to go back and look at any of the other things. And like I mentioned, if you, I just lost my train of thought. I mentioned something and I meant it. If you want to send me questions, I will do my best to be in touch with you as soon as possible. I'm also going to be posting this weekend just a quick survey thing. If you're planning to take the exam with me in person, next Tuesday, I'll have you just sign up for me. Full disclosure, I'm going to bring you treats. So I need to know how many people are coming. So I'll get that posted for you along with any other information that you need. So I'll chill out here for a bit. If you have any questions, feel free to put them in the chat. Otherwise, good luck with all of your studying, and maybe I will see you on Tuesday. If not, please stop by next semester. I'd love to stay in touch. So have a great weekend. Good luck with your studying. To all the thank yous, you are most certainly welcome. I'm happy that I was able to help. Tatum said the wait was worth it. Awesome. Good. Oh, let me turn off our recording.